Dear distinguished guests, ladies and gentlemen, good afternoon, everyone. Thank you for taking your time out of the weekend to participate in this afternoon's meeting. I know we have participants from Sichuan Province, Professor Chuan, Professor Li, and Professor Cai from Chongqing, and Professor Li as well. Good afternoon, everyone. It's my great honor to participate in Best of ESMO 2025 Breast Cancer China session. So we will have some highlights being discussed in this year's ESMO 2025. And also, in today's meeting, we will invite the international speakers to share with us the highlights of this year's ESMO so that the Chinese clinicians will be able to know about the updates and also to make the Chinese physicians' voices being heard as well. And also we will talk about and explore the breast cancer management with the Chinese characteristics and also share the experience and management principles of breast cancer. So today we have two speakers. The first one is Professor Giuseppe Curigliano, who is the president-elect of ESMO and editor-in-chief of ESMO Open, and the other is Professor Matteo Lambertini from University of Genova, Italy. They will share with us the most recent updates from ESMO. And firstly, I would like to introduce the first speaker of today, Professor Matteo Lambertini. Professor Lambertini is from University of Genova, Italy. He's the associate professor and consultant in medical oncology at University of Genova, IRCCS, Policlinico San Martino Hospital in Genova, Italy.
IRCCS Policlinic San Martino Hospital in Genova, and the chair of ESMO Young Oncologist Community, associate editor for ESMO Open. 掌声有请。
Let's welcome Professor Lambertini to share with us.
Hello, hi everyone. Thank you very much for the opportunity to be here today with Professor Curigliano. It's my pleasure to discuss the main studies that were presented at the ESMO Congress in the field of hormone receptor-positive disease. And I was asked to cover 6 studies, so I'll do my best in the next 20 minutes to go over these 6 studies. I'm going to start with the 2 trials in the early breast cancer setting, looking at the CDK4/6 inhibitor as adjuvant endocrine therapy. And I'm going to start with the update of the Monarchy trial showing the first positive overall survival data with the use of CDK4/6 inhibitor in the adjuvant setting. So here is the design of the Monarchy trial. Just wanted to remind, it's a study that focused mostly on cohort 1. More than 90% of patients were included in cohort 1, that used 2 very simple criteria, but very pragmatic criteria to define high risk of recurrence, meaning N2 and 3 disease, all patients were eligible, or N1 disease, so 1 to 3 positive nodes, but in this case, 1 extra risk factor for disease recurrence had to be present, and it could be grade 3 and or tumor size 5 centimeters or larger. So this is overall a high-risk population. Basically all the patients received chemotherapy, and more than 60% of them had N2 and 3 disease. And patients were randomized, more than 5,600 patients were randomized to receive endocrine therapy as per physician choice, could be tamoxifen, could be AI, with or without OFS in premenopausal women. And then on the top of endocrine therapy, 2 years of abemaciclib in the experimental arm. At the ESMO Congress, we have heard the first positive overall survival data from adjuvant CDK4/6 inhibitor. This is the overall survival curve, where we see around 2% absolute difference in overall survival at 8 years, at the cutoff of 8 years, with around 6.3 years of median follow-up, with a hazard ratio of 0.84. And here the subgroup analysis showing that the benefit in overall survival was observed regardless of patient, tumor, and treatment characteristics. There was no positive P4 interaction, meaning that the benefit was observed regardless of all the disease features that were assessed in the subgroup analysis. So far, we can say that the benefit in terms of absolute numbers is relatively small. However, I think that it's already very good news to have such relatively short follow-up to see an overall survival benefit, which potentially could increase over time. And the reason why I'm saying that, because if we look at the number of events in the two study arms, and specifically if we look at the number of patients that died because of breast cancer, the green box in this figure, or patients with metastatic disease that are still alive, which are patients with the green color. Those that died because of breast cancer are in the light blue color. So if we merge these two groups of patients, we see around 5% absolute difference in terms of number of patients in this situation. So we can potentially expect that the OS benefit could increase over time. I think this is a very, very important slide to interpret the overall survival data. This is the first-line treatment that patient received in the two study arms at the time of disease recurrence. And we know that CDK4/6 inhibitor is the current standard first-line treatment with a major overall survival benefit in the first-line setting. And so I think it's important and reassuring to see that in the endocrine therapy alone arm, around half of the patients at the time of disease recurrence, they did receive a CDK4/6 inhibitor. If we had a very small number of patients receiving a CDK4/6 inhibitor in this setting, we could have argued that the benefit in overall survival was observed because of a suboptimal treatment in the metastatic setting. However, this does not seem to be the case. Again, it's reassuring to see that half of the patients receive a CDK4/6 inhibitor in the first-line setting. And then, as expected, in the abemaciclib arm, more patients receive chemotherapy first line because potentially these are patients with a more endocrine-resistant disease. In terms of additional updates from the study, this is another very important figure, probably I would say equally important as overall survival, which is the update of the IDFS curve, the primary endpoint of the study. What we see is the 6.5% absolute difference in IDFS at 8 years. And what we see is that from year 4 to year 8, the absolute benefit in IDFS has become stable. So we can potentially say that this is what we expect. This around 6% absolute benefit in IDFS is actually a mature information. It's what we can really expect with addition of abemaciclib in such a high-risk patient population. In terms of subgroup analysis, same comment as for overall survival. There is no interaction with any of the analyzed subgroups, so the benefit is observed regardless of patient, tumor, and treatment characteristics. And what is very important in the type of IDFS event that patient develop is to see that the vast majority of events that we are preventing with the escalation of endocrine therapy, so with the addition of abemaciclib, is actually distal recurrences. We see around 5% absolute difference in number of patients that develop a distal recurrence in the endocrine therapy alone arm as compared to the abemaciclib arm. And this is the reason why, if we look at the distal relapse-free survival curve, this curve is very, very similar to the IDFS endpoint, with a more than 5% absolute difference at 8 years at the cutoff of 8 years, with a very similar hazard ratio. Again, most of the IDFS events we are preventing with the addition of abemaciclib are indeed distal recurrences, which is what we want to see with an escalation of such therapy. Moving now to the NATALEE trial, the other CDK4/6 inhibitor study that provided positive results in the early setting. This is the study design. There are 3 main differences as compared to the monarchy trial. The first is the use of ribociclib as CDK4/6 inhibitor at a reduced dose as compared to the metastatic setting, 400 milligram day. The second important difference is that the treatment was given for 3 years instead of 2 years, as in the monarchy trial. And the third important difference is that the endocrine therapy partner was an aromatase inhibitor, and so it was with OFS in premenopausal women, and tamoxifen, we know that cannot be used with ribociclib. Finally, the main difference between the two studies is that the NATALY trial targeted also a lower risk patient population as compared to the monarchy study. All patients with not N1 disease were eligible regardless of other disease feature, and also some patients with N0 disease but other high-risk features could be included in the study. Also in this case, almost 90% of the patients received chemotherapy, but if you look at the number of patients with positive nodal status, we see a major difference as compared to the monarchy study. Here we have 20% of patients with N2, N3 disease as compared to 60% in monarchy, and we have around 1/3 of the patient with N0 disease as compared to none in the monarchy trial. At the ESMO Congress, we've seen the updated survival results at a median follow-up of almost 5 years. And what we see is a very similar shape of the curve as compared to what we have seen in monarchy study, with a 4.5% absolute difference in IDFS at the 5-year landmark. So in this setting, similar results, probably slightly smaller absolute benefit as compared to what we've seen in the monarchy study, that to me can be justified by the fact that this patient population has a lower risk of recurrence overall, and so a lower rate of recurrences over time, and potentially the need for waiting for a longer follow-up to see a larger benefit. At the subgroup analysis, again, the benefit was consistent across all the subgroups, so no major comment here on the subgroup analysis. The main one I want to highlight is the subgroup analysis according to the nodal status, suggesting that the benefit is observed regardless of nodal status, including among patients with N0 disease. On the N0 population, I want to stress the fact that the vast majority of patients included in the N0 population are patients that can be considered at a high risk of recurrence because of grade 3, because of prior treatment with neoadjuvant chemotherapy, and or patient with, for example, T3, T4 disease. So it's a high risk N0 population. Similar consideration for the distant disease-free survival or distant relapse-free survival endpoint. The vast majority of events that we are preventing with the escalation of endocrine therapy are indeed distant recurrences also in this study. And so these endpoints have a very similar absolute and relative benefit as what we have seen for the IDFS endpoint. In terms of overall survival, there is no benefit so far in terms of significance, but however, I think that for this specific curve, I think that the comment I made previously on the need to wait a longer follow-up in a lower risk patient population as compared to monarchy, I think it's very relevant, and we definitely need to wait a longer follow-up than the monarchy trial. Also in this study, we do see similar data as we have seen in monarchy, that if we look at patients that are still alive but with metastatic disease, which is the light orange color, or patient that died because of breast cancer, the light blue color, we do see in terms of numerical number a major difference between the AI alone or ribociclib plus AI arm, again suggesting that potentially at longer term follow-up, we may see the survival curve separated more than what we are seeing now. So final comment on the CDK4/6 inhibitor. I think that the ASCO guidelines that were published end of last year, beginning of this year, are still valid after the ESMO update. Both agents have proven to be effective in the early setting. The strength of the recommendation is probably stronger so far for abemaciclib as compared to ribociclib, mostly because of the longer follow-up, the 2-year versus 3-year duration of treatment. And I will say after ESMO 2025, also because of the overall survival advantage that, of course, is very, very critical. Moving now to the metastatic setting, we do have 4 important studies to discuss. The first one is the phase 3 EVERA trial. This is a sort of, I would say, second-line study in patients that progressed on CDK4/6 inhibitor. All of them received prior treatment with CDK4/6 inhibitor. And the study randomized patients to receive standard of care endocrine therapy plus everolimus, and this could be fulvestrant or AI or tamoxifen plus everolimus. The experimental arm was everolimus plus the oral SERD by Roche giredestrant. Half of the patient had a ESR1 mutation, 1/3 of them a PIK3CA mutation. So all patients, regardless of disease features, were included, regardless of biomarker, were included in the study, but the primary endpoint, the co-primary endpoint was the PFS in the specific cohort of patients with ESR1 mutation. And what we see here is very nice PFS data with almost 10-month median PFS in the giredestrant arm. That is almost double than the PFS in the standard of care endocrine therapy alone arm, with a hazard ratio of 0.38. The other co-primary endpoint was PFS in all patients, all comer. And what we see here is that, again, a major benefit with the for the giredestrant plus everolimus arm, with a median PFS that is around 1 month shorter as compared to what we have seen in the ESR1 patient population. Subgroup analysis has confirmed that the benefit was observed regardless of patient or disease features. In terms of overall survival, there is no significant statistically significant benefit yet. However, we do see a separation of the curve suggesting a potential overall survival benefit with this combination, even though the data are still not mature to fully look at the overall survival endpoint. This is an exploratory analysis, but I think it's very important to look at the performance of this combination, oral SERD plus everolimus, in patients without the ESR1 mutation. And what we see is that in this setting, apparently there is no major difference as compared to standard of care endocrine therapy, suggesting that the benefit in the ITT population is mostly driven by the benefit of this combination in the ESR1 patient population. In terms of toxicity, it's mostly the toxicity of everolimus, as we know, and particularly stomatitis, as well as some other GI toxicities. Move to the Victoria-1 trial, which is a study looking again to a similar patient population, so patients that progressed on CDK4/6 inhibitor, and also a minority of patients that received adjuvant CDK4/6 inhibitor. And also this study is mostly a second-line trial, so in patients that have actually progressed on first-line AI plus CDK4/6 inhibitor. This study that investigated a PI3K mTOR inhibitor called gedatolisib in 2 different cohorts of patients, one with PIK3CA wild type, a PIK3CA wild type population, which is what has been presented at ESMO that I'm going to discuss in the next slide. And then the second population is the PIK3CA mutated cohort that has not been presented yet. In this study, it's a 3-arm trial. Standard arm was fulvestrant alone, and then 2 other arms were compared with fulvestrant alone. The first was the combination of fulvestrant plus gedatolisib, and the third arm was a triple combination with the addition also of CDK4/6 inhibitor. So the third arm was fulvestrant plus the PI3K mTOR inhibitor plus CDK4/6 inhibitor beyond progression. In this case, was palbociclib. Before moving to the results, I just wanted to highlight that gedatolisib is a IV treatment that had to be given weekly, 3 weeks on, 1 week off. Here are the results. If you look first of all at the triple combination, so CDK4/6 inhibitor, gedatolisib plus fulvestrant over fulvestrant alone, there is a major benefit with more than 9 months median PFS in the experimental arm as compared to 2 months in the fulvestrant alone arm, with one of the best hazard ratio that we have seen in the past few years, with a hazard ratio of 0.24. In terms of the double combination, so fulvestrant gedatolisib without palbociclib, without the CDK4/6 inhibitor beyond progression, we still see a major benefit as compared to fulvestrant alone, with the PFS moving from 2 months to 7.4 months. We all agree that fulvestrant alone is not the best standard arm in this setting. However, the 2 months PFS with fulvestrant is actually what we have seen in, I would say, almost all the trials beyond CDK4/6 inhibitor. Overall survival, there is no significant benefit so far. However, the crossover was allowed, and if we remove patient that had a crossover, we do see a signal of potential overall survival benefit. However, this is still immature. We cannot really comment on this curve, but based on the PFS data, these are definitely very promising results. In terms of toxicity, the more agents we add, the more toxicity we add to the patient, with the main toxicities given by the inhibition of the PI3K mTOR pathway, as we know from other drugs, being mainly stomatitis, rash, diarrhea, and hyperglycemia. So in terms of how to put together all this evidence into the current algorithm, these are the ESMO guidelines that were updated a few months ago. According to these guidelines, in patient progressing on CDK4/6 inhibitor, we do need to test for some biomarker to decide the optimal treatment option. We need to test for the PI3K pathway, PI3K AKT-P10 for the capivasertib option or the alpelisib option, for ESR1 for the oral SERD, for germline, PALB2, or BRCA1, BRCA2 germline alteration. However, if we look at the performance of the post-CDK4/6 inhibitor trials, and this is a very nice slide presented by Alessandra Gennari at the ESMO Congress, if you look at the 4 trials that looked into combination treatment, so EMBER-3, imlunestrant Rabema, Capitello 291, fulvestrant capivasertib, Evera, giredestrant everolimus, and Victoria-1 with the 2 gedatolisib arms, what we see is that actually the combination arms are those with the longest PFS in this setting. And we can potentially argue that, that this benefit is observed in all comer regardless of molecular features. The main benefit is driven again by ESR1 mutation for oral SERD, by alteration in the PI3K pathway with inhibitor of this pathway. However, with this combination, we also see a signal of activity in patients without this alteration. Moving now to my final 2 studies, I'm first going to discuss a phase 1/2 trial with a new pan-mutant selective PI3K inhibitor called STX478. So this drug is an oral CNS penetrant pan-mutant selective PI3K inhibitor that target PIK3CA mutant tumors that has shown a very impressive activity in mouse models and in preclinical studies. So this is the first phase 1/2 study that reports results with these agents as monotherapy, combined with fulvestrant or combined with endocrine therapy plus a CDK4/6 inhibitor in patients that receive prior endocrine therapies. In this case, it's not 100%, but the vast majority of patients received a prior CDK4/6 inhibitor. Half of them also receive a prior SERD, and around 10% receive a prior PI3K inhibitor. So it's a quite heavily pretreated population. And this study also allowed to include patients with controlled type 2 diabetes. Before looking at the results, in terms of toxicity, again, we see the toxicity of PI3K inhibitor, particularly hyperglycemia and rash, stomatitis, and GI toxicity. However, regarding this toxicity, particularly rash stomatitis, the rate is relatively low. I think it's interesting to look at the hyperglycemia rate in patients with or without prior diabetes, with a way lower rate of hyperglycemia in patients without pre-diabetes condition. In terms of response rate, we see a 20% response rate in such heavily pretreated patient population with a monotherapy treatment, around 30% response rate if we combine these agents with fulvestrant, and then around similar 24, slightly lower response rate if we combine these agents with fulvestrant and a CDK4/6 inhibitor. As final study, I'm going to present the OptiTrop Breast-02 study, which is the study looking at the ADC sacituzumab tirumotecan in patients with ER-positive, HER2-negative breast cancer. So this is a study that randomized patients that with luminal-like disease that receive 1 to 4 prior lines of chemotherapy and that receive prior CDK4/6 inhibitor. 100% of them receive prior CDK4/6 inhibitor. to single-agent chemotherapy, eribulin, capecitabine, gemcitabine, or vinorelbine, as compared to the ADC sacituzumab tirumotecan. This is actually a second, third-line trial in the sense that 43% of patients receive only one prior chemotherapy lines and 40% receive two prior chemotherapy lines. So it's a less pretreated patient population than the TROPiCS-02 trial, but a more pretreated patient population than the DB04 trial. So here the PFS results, we see an impressive doubling in the median PFS from 4.1 months with chemotherapy alone to 8.3 months with sacituzumab tirumotecan and a hazard ratio of 0.35. Subgroup analysis has shown a consistent effect regardless of the subgroup that was analyzed. And we also see a trend for positivity in overall survival with numerically way less events in the sacituzumab tirumotecan arm as compared to the chemotherapy arm. However, this is not mature yet, and we need longer follow-up to look at the overall survival. As expected, also the response rate is favoring the sacituzumab tirumotecan arm with also almost a 20% absolute difference as compared to single-agent standard chemotherapy. So in terms of toxicity, it's very surprising to see that agents with a similar payload, similar target may have different toxicity profile. In these cases, we mostly see hematological toxicities with very low rate of diarrhea, ocular toxicity, and ILD as compared to other ADCs. This is my final slide to just remind everyone that we now have 4 ADCs that have shown positive PFS and some of them also positive OS data in the ER-positive, HER2-negative disease beyond first-line therapy. DB04 with trastuzumab deruxtecan, TROPiCS-02 in heavily pretreated patient with sacituzumab govitecan, and then datopotamab deruxtecan in a similar patient population as DB04. And then, of course, we have in the first-line setting the DB06 trial. With that, thank you very much again for the kind invitation and the opportunity to be here today.
好，非常感谢
Thank you.
咱们这个年轻的这个
Thank you,
给我们带来了
Professor Lambertini, for the sharing on the recent updates of the 7 clinical trials. So one is the Monarch E, another one is the Natalia. The third study is about the ESR1 mutant patients. So in his talk, the fourth study is Victoria 1 study is about the PI3K inhibitor. The fifth study is also about the PI3CA mutant patients. As I understand, the clinical trial is still going on, and the last 2 trials is the TMT SAC compared with the investigator choice of the chemotherapy. So I think the main studies are about the combination of the CDK4 inhibitors with the combinations or versus the investigator's choice of the chemo. So I think some of those studies are quite new. So I think we can have more discussions later. So now I will give you the introduction of the second speaker. And so the second speaker is Professor Giuseppe Corigliano. He is the director.
Steering committee members of the Department of Oncology and Hemato-Oncology at the University of Milan, and President-elect of European Society for Medical Oncology, and the editor-in-chair of ESMO Open, editor-in-chair of ESMO Open.
Okay, thank you very much. I will share my screen. So thanks for giving me the opportunity to do a summary of highlight in triple negative and HER2 positive breast cancer, including early and metastatic. Those are my disclosures. So the first study I would like to highlight is exactly the Destiny Breast 05. This was a prospective randomized trial, including patients with HER2 positive disease, high risk, specifically inoperable early breast cancer, CT4 and 0 and 3 and 0, or CT1, 3 and 2 and 3, who received the neoadjuvant treatment. Patients, if residual disease after neoadjuvant therapy, were randomized to trastuzumab deruxtecan for 14 cycles versus T-DM1, and the primary endpoint was invasive disease-free survival. What is really interesting to understand in this study is that concomitant adjuvant endocrine therapy was allowed, and there was also the opportunity to receive eventually radiation therapy together with trastuzumab deruxtecan. Let's check the patient characteristics. The median age was less than 65 years for 90% of the patients. The majority of the patients were Asian, so you have to consider that almost 48% of the patients were Asian. And in terms of neoadjuvant therapy, the majority of the patients received a dual blockade in the neoadjuvant setting. What we show with this data is that the use of trastuzumab deruxtecan for 14 administration in the post-neoadjuvant setting increased the rate of invasive disease-free survival from 83% to 92%, with the delta of almost 8.7%, a hazard ratio of 0.47 that was statistically significant. So if we use TDX in the adjuvant setting, we have a 53% reduction in the risk of invasive disease. Of course, when you are going to check the rate of distant and locoregional recurrence, it's very clear that the use of trastuzumab deruxtecan can be better than T-DM1, also in terms of CNS localization. The key secondary endpoint was disease-free survival, and also in the context of disease-free survival, there was a reduction from 8.3% to 9.2%, with a delta of 8.8%. So in the secondary endpoint, distant relapse-free survival, brain mets-free interval, and overall survival, the use of trastuzumab deruxtecan was better than T-DM1, and this is really an important achievement. In terms of safety, of course, we have to consider that in the TDX arm, 3 patients died, 2 patients for ILD or pneumonitis, another one for a respiratory tract infection. And in the T-DM1 arm, the cause of death were 1 leiomyosarcoma of the uterus, another one an aneurysm, non-neutropenic sepsis, an ovarian cancer, and a traumatic pneumothorax. What's about ILD? Adjuvant radiotherapy timing showed no difference in adjudicated drug ILD. Overall, the incidence was around 9.6%, with 2 grade 5. And in terms of cardiac safety, there was a very low incidence of grade 3 cardiotoxicity. The second study was the Destiny 11, incorporating trastuzumab deruxtecan in the neoadjuvant setting. In this study, there were originally 3 arms. One was TDX alone for 8 cycles. The other one was the standard of care, AC followed THP, and the last one was TDX followed for THP. So 4 cycles followed by 4 cycles. This was the recommended post-neoadjuvant treatment was based, of course, in the presence or not of PCR or not. And patients eligible to the Destiny 11 were, of course, previously untreated HER2 positive disease with high-risk features of presentation. So tumors more than 3 CT3 and 0 and 3, and also CT0, CT4, including inflammatory breast cancer, and CN1 and 3. The primary endpoint of the study was pathological complete response. The trial was not powered to demonstrate an event-free survival benefit. The majority of the patients were HR positive, 73%. Clinical tumor stage was CT02 in 54% of the patients, CT3, CT4 in 45%. Almost 90% of the patients were non-negative, node positive. In terms of residual cancer burden after surgery, let's say that 81.3% of patients receiving TDX THP had no or minimal residual invasive cancer, because finally the rate was around 84% in HR negative disease and around 63% in HR positive disease, with an overall pathological complete response rate of 68%. So this is unprecedented, of course. So having 68% of pathological complete response with a rate of 84% in HR negative, it's something that is not so common. As I say to you, the study is not powered to demonstrate an event-free survival benefit, but in this unplanned analysis, there is a nearly positive trend for event-free survival. In terms of safety, this sequential treatment was very well tolerated. So the rate of grade 3 or more toxicity was more frequent in the chemotherapy arm respect to the TDX followed by chemotherapy arm. And the incidence of ILD was low, very, very low. So if we check the data in terms of activity of the single arm TDX, you will see here that this was inferior to standard chemotherapy. So the question actually is whether or not TDX pertuzumab followed by standard chemotherapy should be considered a new standard of care. Another study was the DESTINY-9. The DESTINY-9 was a prospective randomized trial comparing TDX placebo versus TDX pertuzumab and THP. And during ASCO this year, we had an interim analysis in which have been presented the data of the combination TDX pertuzumab. The study demonstrated an impressive median progression-free survival benefit that was around 40 months versus 26 months in the arm exactly of the standard chemotherapy. What is really important to understand that in all subgroups, we have exactly the same benefit from the use of trastuzumab deruxtecan plus pertuzumab, independently of HR status, PI3 kinase mutational status, age, and presence or not of brain mets. In terms of outcomes after TDX rechallenge for patients with G1 ALD, the median time to rechallenge was 42 days from the last dose before ILD. And after a rechallenge, many patients remained on TDX for a median of 215 days. 12 patients, 27%, developed a recurrent ILD. Other interesting study was the Horizon Breast 01 study. This was a prospective randomized study comparing SHR A1811 4.8 milligram per kilo every 21 days versus pyrotinib and capecitabine. This is a very interesting ADC in which we have a huge activity in the context of patients with HER2-positive disease, mainly with visceral disease. The primary endpoint was median progression-free survival, and the use of SHR A1811 improved the median progression-free survival from at 12 months from 35 months to 84 months. That was really unprecedented. So median PFS was 8 months with pyrotinib and capecitabine versus 30 months with the ADC. Investigator assessed we had exactly the same results, but what is really important is that there is also a trend for positivity of overall survival. In terms of safety, the median duration of treatment was 19 months. For pyrotinib, only 7.1 months. We observed several toxicities, mainly hematological toxicity, of course, that was the most common, and a very low rate of ALD, because finally the incidence of ILD with this ADC was around 2.8%. In conclusion, trastuzumab rezetecan improved median progression-free survival and overall survival when compared with pyrotinib and capecitabine. The median PFS was a median of 30 months versus 8 months. And in terms of safety profile, we have a positive trend with only a 2.8% of ILD. So I really believe that trastuzumab rezetecan is a new kid on the block. We need to do a clinical study also in the Western population. Another ADC was trastuzumab botidotin. This was a trial for HER2-positive disease previously treated with TDX and pertuzumab in the metastatic setting. And in this study, of course, there was a comparison of trastuzumab botidotin versus T-DM1, and the primary endpoint was PFS by blind and independent central review. These are the patient's characteristics. Less than 65 years old, at least 86%. The majority of them, of course, with visceral mets. And trastuzumab botidotin improved the median progression-free survival from 4 months to 11 months with an hazard ratio of 0.39 and the trend of overall survival. In terms of response rate, overall response rate was closer to 77%. So I believe this is another ADC with a very important activity. In terms of toxicity, unfortunately, ocular toxicity was a main issue for this drug. And of course, also ILD, but even if the incidence of ILD was around 1.1%. So 2 new ADC coming from China, trastuzumab rezetecan and trastuzumab botidotin, both with an impressive activity in HER2-positive disease. Both, again, as I said, that need a replicative trial in the Western population. We go now to the triple-negative disease. This was an interesting study, a study on financial toxicity, let's say. So this study used a lower dose of pembrolizumab. I don't know how much this data can be really extrapolated in the real world, because this study is a small study, 160 patients, randomized to receive chemotherapy alone versus chemotherapy with 50 milligram of pembrolizumab. I don't know what you are going to save giving 50 milligram. In any case, these were patients with triple-negative disease, 70% of them less than 50 years old, many of them with that CT3, CT4 patients and overall stage of 55% stage 3. Of course, HER2-negative disease and triple-negative. The rate of pathological complete response in this near equivalent study was 40% in the chemotherapy arm, 53.8% in the chemioimmunotherapy arm, with an absolute difference of 13%. In terms of pathological complete response, of course, 56%, that was not bad, and residual cancer burden was 0.1, usually 71%. In terms of quality of life, very similar quality of life. So in the context of financial toxicity, if you use low-dose pembrolizumab, you can achieve a reasonable rate of PCR. Of course, to confirm this, we need at least another confirmatory trial. Another study was the ASCENT-03, first-line triple-negative breast cancer, sacituzumab govitecan versus chemotherapy, primary endpoint median PFS. Sacituzumab demonstrated an improvement of median PFS from 6.9 months to 9.7, also investigator assessed, with a duration of response around 12 months, but unfortunately no difference in overall survival, because the majority of the patients on chemotherapy arm did a switch to sacituzumab govitecan. In terms of safety, no new safety signal. Of course, hematological toxicity and diarrhea, the most common toxicity. And in this case, of course, this can be considered a new standard of care. The other update was the ASCENT-04, Saci pembrolizumab versus chemotherapy pembrolizumab. Data on quality of life have been presented with the primary analysis. Of course, there is not so much difference between chemotherapy and ADC plus immunotherapy. The time to first deterioration was very similar in the two arms, and also the deterioration in physical functioning. When we are going to consider specific items, of course, the quality of life for diarrhea was poorer in the sacituzumab arm. But in any case, we can say that the use of an ADC plus immunotherapy is not inferior in terms of quality of life to chemotherapy plus immunotherapy. So thank you very much indeed.
好，非常感谢主席的这个精彩的演讲。这个他是跟我们
Thank you very much for your kind sharing. So I think Professor has shared with us the DB05 study, and this is also the comparison about TDXD and TDM1, and also the DFS, IDFS, as well as other data have been compared. The second study is DB11. So for DB11, TDXD followed with THP versus the DDAC followed with THP. So that's in the neoadjuvant setting. And so PCR, we do see differences. The third study is DB09. So DB09, that's the MBC patients with HER2 positivity. And so for TDXD with pertuzumab, and the conclusion is the combination with the pertuzumab is superior than THP. So that's for ABC. And the last part is about the Horizon D01 study, and is to compare the Puritini with capecitabine versus the 1811. And so the PFS has been compared with a lot of difference. The fifth study is the trastuzumab with the two new drugs. I'm not very familiar with those two new drugs, and so I think the difference is not that big. The six to the eighth studies about TNBC, and so for the sixth study is the early stage, is the EC follow T, and also for EC follow T with pertuzumab, and also for the pertuzumab combination, PCR is better than the control arm. So for those patients, if we are able to combine with the immunotherapy, that is good. For seventh and eighth studies, well, they also study the advanced TNBC patients utilizing SG versus the chemo, and also the conclusion is that the PFS and OS of the SG group is better than the investigator choice way of the chemo, and another study is the SG with the other ADC. So I think we didn't see huge differences. So I think there are not informations. So 20 minutes, I think you went through all the studies according to the agenda of today's meeting. So thank you to you very much.
Thank you to you.
So
according to the agenda, we will enter into the panel discussion. So for the panel discussion, we have online panelists. We also have the local panelists joining us from the site. So for this panel discussion, we have 4 panelists who are at the site. They are Professor Chai Fan from the Chongqing General Hospital, and also Professor Li Junjie from the Sichuan Cancer Hospital, Professor Chuan Yi from the Southwest Medical University, and also Professor Yin Xuedong from the First Affiliate Hospital of the Chongqing Cancer University. So please take your seats on the stage.
我就走你这边就行了。按照刚才的顺序，第一个来答案，站在前面，我们每个人对个话筒。咱们这个其实他们有设置的这个讨论的话题
So we prepare some questions in advance. And also, I think you can feel free to raise up your questions to our two distinguished professors online.
那么第一个话题是
So the first question.
在这第一个话题是可能第一个讲。
The first question is as novel endocrine agents and PIK3K, AKT, and mTOR pathway inhibitors continue to emerge for HR positive ABC based on the latest data, which clinical benefits can these therapies offer the patients? Can they overcome the remaining therapeutic challenges? Over to you, Professor Chai Fan. Thank you. Thank you very much for your kind introduction. So for the first question, based on the recent updates of the clinical evidence in terms of the clinical benefits for the PAM pathway inhibitors, it has the following features. On one hand, actually, in the breast cancer field, it is the most commonly mutated pathway. With the emergency of those novel therapies, with early or late intervention, we are able to overcome resistance based on the endocrine treatment. On the other hand, coming back to the clinical trial data, they are still in the late line setting, so they can only overcome the resistance. Right now, we don't see any of them that have come to the first line setting. So for this question, what are the benefits can they bring and also overcome the current challenges? So firstly, in terms of the benefits, it can improve the PFS. We know that for sure. We also know that right now in the endocrine treatment, in the later line, CDK4/6 inhibitors have been widely utilized in the first line. I mean, we usually now we use CDK4/6 inhibitors as the backbone. And so nowadays, for those first line treatment in the advanced stage, the PFS nowadays can be 20 months with those new therapies. But actually, after 20 months of the PFS, we will see progression. I mean, nowadays we see so many different therapies. I mean, in the past, we only have one CDK4 inhibitors in adjuvant consolidation treatment. And also, sometimes we see patients that even would have progression during the adjuvant treatment. So CDK4/6 inhibitors can only offer the protection in the first phase. And nowadays, PAM pathway is a pathway that has been very well studied. Nowadays, we also have the PARP inhibitors or HDAC inhibitors from China. And also, we even have the ER inhibitors. The current status is that majority of those patients, like for those new patients, when they use the CDK4/6 inhibitors, the trickiest part is that what can we do if they progress on CDK4/6 inhibitors? And we also have the PAM inhibitors, like the Victoria-1 study. I think a very interesting point is that for the PI3K wild type pathway has also been studied with a combination of fulvestrant. We can see the patient's survival has been improved, especially in the subgroup analysis. You can see the benefits are independent of the CDK4 inhibitors. I mean, for FLAR-1 study, I mean, with a triplet, we're able to reduce the risk. So for this study, it tells us that we don't need to even consider prior line treatment of the CDK4 for Captillo 291 with the combination of the fulvestrant HR could be 0.62 and China's HR is 0.51, even though price is high. And so each month the cost is around $30,000. Not every patients can afford it. I mean, if we use it in the second line, not all the patients can afford it. And for the inavolisib, and so based on the NOVA 102 study, I mean, for the combination, the PFS has been prolonged to 7 months, even though it has been doubled, but PFS is still just 7 months. So what can we do after progression? My personal idea is that it solved some issue post CDK4/6 inhibitors, but not all the questions have been solved. So no matter what we add on, we still need to think about resistance issue. Right now, for CDK4/6 inhibitors, now we're in the area of CDK4/6 inhibitors, maybe based on maintain molecular plus, actually, it's only be like benefits of 5 to 6 months. How can we better prolong PFS too? That's very important. Another important thing is about the safety. Major AE is the stomatitis, the hypoglycemia, as well as the mucosa damages in the skin. And because we would also see hyper and hypothyroidism of those patients. And so we need to pay attention to those issues. Another one is the accessibility, because some drugs, they are available, but the price is too high. So for post-CDK4/6 treatment, I think for some good drugs, accessibility is still an issue. Another important thing is about the biomarker. Nowadays, we only have the big panel to cover PI3K pattern. I mean, for the smallest panel, actually, the cost is around 6,000. A single pathway test, the cost would be 1,000. So it is still a little bit too expensive. So I mean, maybe in half years time, we still need to think about what can we do in given those high costs. So how can we gain breakthroughs for the current challenge? We need to have a forward thinking, a long-term view for the PI3K inhibitors. If we have wide use, we would also have resistance issue. What is the mechanism of the resistance? I mean, for the post or late line treatment, maybe the duration of the benefits couldn't be that long. And if we use then in the second line way, pretty good results. Can we also move it to the first line in combination? But if we add on in the first line setting, but toxicity would also be further mounted, and we have a better marker to do the detection of the PI3K, AKT, and TUR pattern. Another interesting thing is PICALO-1 study. So for the PI3K mutation, after the mutation, we would also choose the pan inhibitor. Some with high toxicity, some have lower efficacy for PICALO-1. This study is very interesting. That's a pan PI3K pathway inhibitor. For phase 1 and the phase 2 studies, the activity is not that high with lower toxicity. So with this better formulation, I think it's gonna fulfill a better role to better treat those patients. So I think in the second line setting, I mean, or in the third line, it can solve some issues. But if we really want to truly solve those challenges, we also need to solve the accessibility issue. And sometimes when we have the resistance, we may still have to come back to chemo and other pathways. So I think we need to do more studies to, solve all the issues and the questions. Thank you, Professor Chen, for the wonderful sharing. So I think what you have shared with us are actually the things that we also face on a daily basis. And so for the testing, for the gene testing, when should we do it? It is also a key issue. I think the best timing will be upon first diagnosis. It's better for us to do the gene testing. But actually, majority of the practices will be like do the testing upon progression. And actually, normally we cannot begin with big panel. The cost is 9,000, 10,000 RMB. But actually, for small panel, my hospital, the cost is around 800. So it is mainly for PI3K pathway. However, with different reasons, especially because of the high cost, we cannot do the gene testing upon the first diagnosis. So if we have recurrence and metastasis, I understand with the gene testing, we can better forecast the prognosis. I mean, if we're able to do this test upon first line setting treatment decision, I think it's going to be more helpful. We hope that in the future, we can cut the price down further. We hope that we can further improve the accessibility to all the patients. And so that at the first line setting, if we're able to do gene testing, we can do better decision making and choose the best therapy for the patients. And so now we'll move on to topic 2. The topic 2 is that updated long-term follow-up data from MONARCH-E and the NATALIA studies were presented at ESMO 2025. How might these findings affect adjuvant therapy for patients with HR-positive EBC patients?
Thank you, Professor Liu, for the invitation and introduction. And also, I would like to thank our 2 overseas speakers for their excellent talks. And follow up on what Professor Chai has commented, and also about the PAM pathway. In my clinical practice, I have used the capivasertib and idanalisib. So basically, in my practice, Professor Liu mentioned about their small panel, which is 800 RMB. We also have a small panel that includes PI3K, AKT, PTEN. The cost is actually 7,000 RMB. We also need to address the issue of mutation VAF and the abundance. So this is not being mentioned in clinical studies. I know that this is a session we can also ask some questions. So later I may want to ask a question. So I will make a comment first. So now we have a lot of pathways that can be tested. And after testing, now we are all focusing on precise molecular diagnosis. And with the molecular diagnosis, do we have a tool that can help us to calculate that, for example, the mutation of one pathway for the proliferation, metastasis of the tumor, how much weight does that pathway play? And for example, for some of the pathways, if the weight is very small for a certain pathway, that it would basically have a very little role in the tumor growth or progression, then what should we do? And also about the mutation abundance, the VAF. So for example, a patient who previously had PI3K mutation and has no PTEN, and in this case, we have decided to use the capivasertib. So for patients with very little mutation VAF, so comparing to the disclosed data, will these kind of patients have basically worse response than what's been demonstrated in clinical studies? I would like to also hear from our overseas speakers, because for capivasertib, for example, it's very expensive. So the patient, after paying such a high price, will have a very high expectation. So we need to consider all-rounded factors. So I think for these genetic factors, we have to consider, and also economic factors will also have to be considered. So that's basically what I would like to comment. Follow up on what Professor Cai just mentioned. I think it's already very comprehensive. So that's also a current question that I've always wanted to ask about testing different mutation pathways and also the mutation abundance of different pathways and how much weight they can play for the actual tumor growth of an actual patient. So I think sometimes for some patients, we probably will save this kind of testing as a last resort, but I think maybe we can do the testing earlier so that we can have better decision making. For PI3K, it's more stable mutation. So basically, PI3K from liquid biopsy, from the primary lesion and metastatic lesion, PI3K mutation is more stable. But for other mutations like ESR1, it's less stable. Then I think the treatment strategies may be slightly different. And then back to question number 2 about MONARCH-E and NATALIE. We have used these 2 CDK4/6 inhibitors for multiple years in practice. So with more data being read out, with the OS data being shared, I think we probably will have more confidence as clinicians. And also for treatment strategy making, we will be more confident in making clinical decisions. And after data readout, you can see in terms of side effects and also dropout. And basically in our clinical practice, we need to consider these and also the doses. These are actually things we need to pay attention to in our daily practice. For abemaciclib, based on my experience, I usually use a dose escalation for abemaciclib to build tolerance for abema. But of course, we do have real-world data to support that because some patients, to start with 150 dose, some patients cannot tolerate. And also some patients, they may discontinue the treatment and then restart like in an intermittent way. I think for these patients, more than 50% of our patients, they will actually experience this process. So previously, when we start with 150, we will have this problem. So now I prefer to do dose escalation for abemaciclib. So start from 100 and then gradually up titrate to the standard dose. But of course, now the insurance doesn't allow us to do that. You have to start with the standard dose and then gradually taper the dose. So I think, of course, we would like to see more data being shared, but what we pay attention to as clinicians is in real world practices, what should we do to better improve long-term survival? I think this will be more meaningful to guide our clinical practice. I've always been focusing on side effects management and also dropout rate. These are two very important things for clinicians. And then for Natalie data, for ribociclib. And we believe that next year, ribociclib will be covered by the medical insurance. So more patients will be benefit from that for those who are, for example, Endura. So for patients who fits the inclusion criteria, eligibility criteria of both trials, which one should we select? So now with the similar insurance coverage, basically now ribo is not being covered by medical insurance, so we will choose abema which is covered by medical insurance. But once ribociclib also being covered, how should we choose? So of course, some clinicians will think about the side effects because ribociclib may have some issues with the QT interval. So for patients with underlying heart disease, hypertension, then we probably will consider a different drug. And for those who have gastrointestinal reactions during chemotherapy, then we need to consider whether we should choose abemaciclib. And also in Natalie trial, the dose is more flexible, like 200 milligram, etc. So if we are going to make some adjustments, this is easier for us. So now with the data update, I think for me, I would like to know more details. I'd like to know about the dropout rate, side effect management, what will be the impact of the side effect, etc. So I hope that I will be able to learn more about detailed data, but of course, always benefit for clinicians. This is, of course, something that can boost our confidence. This is also quite meaningful to guide our clinical practice. A very good thing to have the OS benefit being reported. That's it from my side. Thank you, Professor Li, for your sharing. For CDK4/6 inhibitors, I think you have shared a lot of insights and clinical experience with us, and also shared in his clinical practice some of his feedback. So firstly, we're going to move on to discussion topic number 3. Based on DB11 and DB05 research data, what is the anticipated impact on perioperative therapy for HER2-positive early breast cancer? I'd like to invite Professor Chen Yi to make a comment on this question. Thank you, Professor Liu, for the invitation. And this is a very informative session. For Destiny Breast 11 and Destiny Breast 05, I would like to talk about my personal experience for breast cancer management. So we know it's a systemic disease. So surgery, chemotherapy, radiation therapy, targeted therapy, we need to have comprehensive treatment so that we can improve prognosis of breast cancer patients. For HER2-positive breast cancer, in early stage, now neoadjuvant treatment is the treatment standard. So the purpose of neoadjuvant treatment is based on the characteristics of the tumor. For example, HER2-positive and triple-negative tumor may be bigger, and also in the neoadjuvant setting, we want to downstaging and also to preserve the axillary. And also neoadjuvant therapy, neoadjuvant treatment can be a period of time where we can have some sensitivity tests so that we will be able to compare the treatment results and help us to decide the subsequent treatment plan. So with the neoadjuvant treatment, we can individualize treatment for individual patients and improve patient prognosis. So for neoadjuvant treatment, neoadjuvant therapy, for those who achieve past CR after neoadjuvant treatment will have better prognosis. So in the neoadjuvant stage, I think a very objective standard to evaluate response is the PCR rate. This can help us to understand the prognosis and possible outcome. So to pursue higher PCR rate is one of the target in neoadjuvant stage. For HER2-positive breast cancer, we have a lot of studies being conducted in neoadjuvant setting, including the NeoSphere and also the downstaging trial, TRAIN2, etc. So we have a series of trials, and their neoadjuvant PCR rate is around 40 to 60%. And since we have mentioned before that those who achieve PCR after neoadjuvant therapy will have better prognosis, then of course the higher the PCR rate is, the better. Currently, the PCR rate is 40 to 60%. We hope we can increase the PCR rate. And for TDXD, from the DB series of studies, we can see it's been moved from later lines more to the earlier line and to the first line. So because of very good result, it's now being constantly moving forward to earlier lines. So DB11 is a trial in neoadjuvant setting compared to DDAC followed by THP. I would like to ask our international speaker here. So now in the domestic guideline, usually for TCBHP, so far this is basically the most common treatment, and also for this DDAC followed by THP. It's actually being used in adjuvant setting, but less common in the neoadjuvant setting. So later, maybe our speaker can share with us that for this chemotherapy, DDAC followed by T, seems that it's more commonly used in Europe and United States. So we would like to know in their real-world practice, DDAC followed by THP in the neoadjuvant setting, how well is the response? So for patients with, for example, very high tumor staging, how's the response? So if it's being very commonly used in their clinical practice, then for DB11, the positive result of DB11 for our future clinical practice, using this chemotherapy in the neoadjuvant setting, we will have more evidence, we will have better confidence to use this chemotherapy in the neoadjuvant setting. So for DB11, the result, we can see for T3, T4, they account for 45%, and also more than 90% are lymph node positive. And also we have around 20% that are triple positive. So for triple positive patients, their PCR rate is usually lower than those who are HER2 positive. So basically, the population is more high risk, but of course, there's an advantage for that because in the adjuvant and neoadjuvant setting, now for anthracycline, the accumulated heart toxicity is a concern. So we have a trend of trying to achieve anthracycline free. And also the sequential use of treatment can help us to reduce toxicity and also reduce resistance, I believe. So with DB11, I think the result has further increased the PCR rate in neoadjuvant setting. So I think apart from my previous question, if this question can be answered, this can be another option in my practice because the PCR rate has been improved.
So for DB05 study, I mean, through neoadjuvant treatment, we have the PCR and non-PCR patients. And so for the PCR patients, they have better prognosis. For non-PCR patients, they are more likely to relapse. And so they have high risk of the metastasis and relapse. For those patients, we need to do escalation. Through the escalation treatment, we help are able to improve the prognosis and then to improve the overall survival of the patients. So for DB05 study, actually in the TDM1 study, based on the HER2 positive non-PCR patients, actually TDM1 has also been put into the guideline based on the positive study. And for TDM1, actually, I mean, we have a lot of thrombocytopenia for TDM1, and if we use the 3.6 milligram, many patients would have very severe thrombocytopenia, and that's why we normally in China would start from 3.0 milligram. And so for DB05 study, actually following the same concept, through the escalation adjuvant treatment, we hope to improve the survival and the prognosis of the non-PCR patients. So I think for DB05 study, it is a head-to-head comparison study. IDFS, DDFS have shown benefits. At the same time, we didn't see extra safety signal. So safety profile is pretty good. So based on those data, in the future clinical practices, it gave us a new choice for the non-PCR patients treatment. Okay, that's all from me. Thank you, Professor Quan. So what about your question? So for DB11, for DDAC following THP, now is it this routine? And so how about the real world study? So two professors, Professor Giuseppe and Professor Lambernetti, could you share with us your comments?
Yes, of course. If you could check the clinical practice guidelines of ESMO and ASCO, still anthracycline can be used. Why you believe it's not a standard of care? If you have a CT4D with a hormone receptor negative disease, you can use also the anthracyclines. So here the problem is not the comparator arm. Here you should check the data. We have something like 82% pathological complete response in HR negative, more than 60% in HR positive. These are good data, in my opinion. And the sequence of the treatment is less toxic than standard chemotherapy. So why discussing about the control arm if incorporated in all the clinical practice guidelines? These are high-risk patients. So many people, at least in Europe, still use anthracycline. I agree with you that TCHP is also an excellent standard of care. But when you compare TCHP to anthracycline following by taxanes, there is a near equivalence. There is no superiority of THCP. So personally, I believe the trial is giving us important information. Then it's up to us if we want to use or not this regimen, if it will be approved.
他好像是回答的就是顺便问一个问题，他
Another question is that because in DB11 study, HR positive and HR negative patients are different. So for HR negative patients, the PCR is different for HR positive patients. So is there any measures that to make a difference?
But in any clinical trial, the HR negative disease usually has more PCR than the HR positive. So this is you can find this in the NOAA trial. in the neoadjuvant trial with pertuzumab, trastuzumab. Usually HR-negative disease has a rate of pathological complete response that is higher. So this is related, of course, to the biology of the disease. In the triple positive disease, the rate of PCR in all the clinical trial in the neoadjuvant setting, including the Neosphere, is lower usually.
谢谢。那么刚才那个全教授把他
So
的这个关
Professor Chuan also shared with us the HER2 positive patients treatment insights. So, and also shared with us his personal experiences. I mean, for TDXD and ADC drugs like TDM1. And so Professor Chuan also shared with us his personal insights. So the fourth study is that based on the latest results, what options do you choose for patients with advanced TNBC who are ineligible for first-line immunotherapy and why? Thank you, Professor Liu, for the kind invitation to this meeting and also to have the joint discussion about the TNBC treatment. And just now, two professors also shared with us the recent updates from this year's ESMO. Actually, for triple negative patients, we know that the treatment is kind of slow in terms of the progress compared with HER2 positive, HR positive patients. And actually, around 2019, the backbone triple negative patients were still chemo. And so back then, I was in the US attending San Antonio meeting. And so at that time, we had the readouts of the immunotherapy for advanced triple negative patients. OS benefits was not that high. However, the p-value was smaller than 0.05. And PFS has statistical significant differences, so that's why immunotherapy has been added to the treatment of triple negative patients. And so we know that in addition to immunotherapy, like for SG as well as the HER2 low expression patients, and nowadays we can use the regimens, I mean, for the patients that are ineligible for first-line immunotherapy. I think for different experts may have different practices because we know that right now in China, immunotherapy cannot be reimbursed. So if we use immunotherapy, some patients cannot afford that because like for 1 year treatment cost, it's going to be more than 100,000 RMB. So when we communicate with the patient, and so if they cannot afford it, we will switch to other drugs. But if the physical condition is ineligible for immunotherapy because of the comorbidities. So in those situations, how can we better treat those patients? We can also refer to multiple guidelines. So in addition to immunotherapy, I mean, we also have the olaparib study that's for BRCA1 and BRCA2 mutation test. So if we say BRCA mutation, and so according to the related study, we can use the olaparib, and from the study, they compare olaparib with the TPC, and that's the monotherapy of chemo by the investigator's choice. The result is that olaparib is superior than TPC. So I think for the triple negative patients, firstly, we can do a test of BRCA mutation. And in clinical practices, the BRCA test is comparatively cheap. Patients can afford that, unlike those big panels, which may cost more than 10,000. So for TNBC patients, advanced TNBC patients, if they are ineligible for immunotherapy, we will do a BRCA test for this patient to see if they have the mutation, and then we can use olaparib. And actually, olaparib is not reimbursed either in China, so we still have many limitations. I think we still need to follow the guidelines. At the same time, we can also see ASCENT study, that is a phase 3 study about SG. So that's the sacituzumab govitecan, that's TROP2 target ADC. The conclusion from the study is that for SG, it is superior than the chemotherapy. And actually for SG, when we use this drug, actually we also have limitations that it is not reimbursable. I mean, no matter is the biosimilars from China or foreign countries, the cost is also very high. Each cycle, the cost is around 10 to 20,000 RMB. We also use the SG for several cases. It can work. I mean, for triple negative breast cancer, just like Professor Lin Junjie mentioned, actually those tumors have very quick progression. Abundance is also low. I also still have some questions in this study. We didn't pay attention to the TROP2 expression level. I mean, in another meeting, we had a question for the discussion. Can we, do the TROP2 expression level to decide whether to use the drug or not, like ERPR and HER2? And maybe we can do the test of the expression of the TROP2 and then guide our use. So, I mean, for this, Professor Lambertini, so for the TROP2 expression level, do you think is it necessary to do the testing? And also based on the expression level to guide our treatments with the SG, and maybe we can design a trial to study this, because not all the triple negative patients that have the TROP2 expression would be so beneficiary. And also for DB04 study, we know that it is a HER2 low expression study. That's the use of TDXD compared against TBC. So we can see in the past for TNBC definition is the HER2 negative and also ER negativity. And nowadays with the TDXD emergency, we saw the HER2 low expression patients. Nowadays, they can also be indicated for TDXD use. So from this trend, we can also say for the subgroup analysis, for the ERPR negative, HR negative, and HER2 low expression patients, the PFS in experimental arm is 6.3 months, OS is 17.1 months, and for the control arm TPC group PFS is only 2.9 months, OS is 8.3 months. So from those data, we can see for low expression patients of the HER2, we can also use the TDXD. I mean, in addition to that, we can also see that for those drugs, we know that for TDXD, it is now reimbursable in China. So I think for patients that are ineligible for first-line immunotherapy, maybe TDXD can be a good choice. It is reimbursable, it is highly accessible, and so for toxicity, they're also manageable. So I think, of course, if patients can afford, maybe we can use other drugs. Another thing that we need to pay attention to is chemotherapy, because we know that the chemo is still backbone TNBC treatment. I mean, for CBSG, 008, and to compare the nab-paclitaxel with the cisplatin versus capecitabine with cisplatin, and we also compare GP versus GT regimen. And also we can say in the chemotherapy field, we can use them to prolong the survival of those patients. So I mean, when we use those drugs, we need to consider accessibility, reimbursement, policy, as well as the acceptance of the patients, because for advanced TNBC patients, the treatment will be a lifelong treatment. I mean, if you ask patients to sell everything they have to do the treatment, it is something that they cannot accept. And of course, like previous speakers mentioned, for gene testing, it's also very important. I mean, for TNBC, if they progress on all those drugs, how can we treat them? Like for the BRCA mutant, we have SG or olaparib. If they progress on the two drugs, how can we treat those patients? I mean, will you use gene testing to use like bevacizumab, or do you have any other targets that have not been approved with breast cancer, but they have been approved with other tumors? Because for off-label use, there will also be many issues. So how would you choose in your practices? I mean, for Professor Giuseppe and Professor Lambertini, maybe you can also share with us your off-label use in those patients who progress on all those available drugs. Because I understand for foreign countries, I mean, they can do many outstanding clinical trials. One reason is that they have a lot of very good basic studies. They also have very quick translations of basic studies to clinical trials. And that's why China is also catching up with all of you. And also we can see nowadays there are so many original drugs that can be utilized in the treatment. So the first question is the test of the TROP2 expression. Will Nurtini do that and also get a treatment?
Excuse me, I have to apologize, but I have a transfer to the airport because I am in another city. So I thank you very much for the invitation, but I have to leave. Sorry, really, sorry.
Okay.
Yeah, regarding your question, I think that the first one was related to biomarker testing. So for TROP2, we actually don't need to test because the efficacy, it's normally highly expressed in breast cancer overall. And based on the efficacy data we have, it seems to work regardless of TROP2 level, even though there's a tendency for better responses, the higher the TROP2 expression. But in any case, also the guidelines are not recommending to test for TROP2. For HER2, this is very important to be properly assessed because in triple negative HER2 low disease, the only indication we have for trastuzumab deruxtecan is for the HER2 low. So 1+, 2+ FISH-ish negative. We cannot offer TDXD in the ultra low population, so the 0 with some expression. This is only in the DB06 trial, which is the first line trial in ER-positive, HER2-negative disease. So for triple negative, we need to have 1+ or 2+ FISH-ish negative. Then, if I understood well, the second question was on the sequencing. We do have very limited data, mostly from real-world evidence, that the second ADC works less than what expected from clinical trials, which is also something that we expect, we would have expected even before seeing this data. In my practice, I tend to prefer the ADC over standard single agent chemotherapy, so I do sequence them in the triple negative or ER-positive, HER2-negative disease. And I also confirm that I do see less efficacy of the second ADC. Doesn't matter if it's TDXD first as G second or the other way around, the second ADC performs less than in the clinical trial. Regarding beyond ADC, this is a data-free zone. The best will be to include patients in clinical trials, maybe with new agents, with bispecific antibodies, with effective therapies, potentially new effective therapies. I personally do not use a lot bevacizumab, to be honest, and if I use it, it's only in the first line setting. So I will go back to standard single agent chemotherapy, eribulin, capecitabine if not used earlier, and so on.
好，谢谢殷教授的分享啊。
Thank you, Professor Ying, and also I would like to thank our two overseas speakers for their answers.
那么是这个样子啊，我想
I think
现在大家就趋势
because
就是
for
有
TNBC, triple negative breast cancer, we have a lot of
这个
questions. Some patients,
就是有的病人
we treat these patients and then they're gone. So sometimes they seems to be in early stage.
这部分病人，那么刚才谈到了，我们就
So they deteriorate very rapidly. So we have talked about the immunotherapy before. It seems that in different guidelines or different consensus,
我们要 CPS 的检测
for example, for CPS testing, and for a period of time, I remember we require more than 20% of CPS so that we can use immunotherapy. But for some people, they believe if the positive rate is 1%, then we can try immunotherapy. So basically, I think different people may have different understanding and different perspectives. And now for early stage in triple negative breast cancer, we are probably not using that quite a lot. So I don't know for the CPS score for immunotherapy, what kind of cutoff do you use? So as long as it's positive, then you start using immunotherapy, or maybe based on your experience. For example, if the CPS is only 1% positive, then we can start immunotherapy. Or we can see from the clinical trial we talked about before, basically, we also need to think about, should we use immunotherapy in a neoadjuvant setting or after recurrence or metastasis? So maybe we can also add in the second line. So I would like to ask, in your clinical practice, how do you determine the use of immunotherapy? Thank you, Professor Liu. I think your question is about neoadjuvant, adjuvant, and also salvage. So my personal view is, in the neoadjuvant setting, we will still strictly follow KEYNOTE-522 in using pembrolizumab. We still need to test and get a CPS score so that we can have a better idea. So in my clinical practice, for those with less than 20% of CPS, they also respond really well, sometimes even better than the ones with higher CPS. Of course, now we still need to consider the availability, etc. So I think as long as the patient agrees, we probably will use it. So for KEYNOTE-522, it's a quadruple combination, and adding immunotherapy, it's already very high PCR rate. So basically, only one patient in 6 will not achieve PCR. Most people will achieve PCR. So we're happy to see that. And now with the PAP program, so once the patient can sign informed consent of using that, we will basically start using that. And also in the adjuvant setting, if they're not using pembro in the neoadjuvant setting, then we don't have data to support immunotherapy in the adjuvant setting. And in the advanced stage, pembrolizumab, based on the overseas data, pembro has a dozens of indications being approved overseas. Basically, the CPS score for different tumor type is different. Sometimes they use TILs, sometimes they use different CPS, more than 10%, sometimes more than 20%. So one drug with different indications, there's different CPS cutoff. So I think in one perspective, CPS may not be that important. Maybe it's only for the purpose of a statistical stratification. And then for patients who are not suitable for first-line immunotherapy, for these triple negative patients, and basically what we can choose is chemo immunotherapy. If, for example, they are not eligible to first-line immunotherapy, then it's availability, accessibility, or poor response. Then we go back to chemo. Well, I think we should think about its prior lines of treatment, whether they have used paclitaxel, anthracycline, and whether they're resistant to that, and also if they have used anthracycline, then whether the tolerance, whether their heart can tolerate that. So we probably can still continue to use anthracycline. And also for some patients, after recurrence, we need to retest the tumor characteristics. It may still be triple negative. However, the TILs, PD-1 expression level may change. So we need to have different consideration. And also, according to ASCENT-03, for the ADCs comparing to chemo, we're seeing a better option, better treatment option. We have, of course, SKL264 in China, but the indication so far is being only approved for 2 lines and later, which limits its use in the first line. So now we have some new studies, I believe, can help us to address some questions. For example, bispecific antibody, the PD-L1 and IL-8 bispecific antibody can help reduce resistance to PD-1, and also NSUN2, some new targets. We have also seen some data in triple negative breast cancer. So in terms of immunotherapy, we don't have much options, but I think we still have more possibilities in the future. And also the first question, I have the same question as Professor Li. We would like to ask Professor Lambertini.
First, what's your opinion about PAM pathway gene test in your clinical practice? In MBC or EBC, what's the best time point you test this mutation? Question number 2, maybe in Europe, you have better drug ability for the PAM pathway inhibitors. So in China, we have a much big price or shortage. So when in Europe you have both PAM pathway inhibitors, what's your prefer in your first line prefer? So what's your opinion? 2 questions. Thank you.
Yeah, thanks a lot for your question. In terms of testing, so we are talking about ER-positive, HER2-negative disease in the metastatic setting. So we have a public health system, so I'm testing only if I have a drug that I can offer within the public health system. So the drug that we have approved are elacestrant, the oral SERD by Menarini, in patient with a ESR1 mutation. And then we have capivasertib, so the AKT inhibitor together with fulvestrant in patient with PI3K AKT PTEN alteration. So for the ESR1 mutation, you have higher chances to find it, the longer the duration of AI aromatase inhibitor-based treatment. So normally we do a liquid biopsy at the time of progression to AI plus CDK4/6 inhibitor to check for the ESR1 mutation. And then at the same time, we do also the PI3K AKT PTEN pathway. However, the PI3K AKT PTEN pathway can be also tested earlier because this is not a mechanism of resistance. This is a truncal alteration. So it's there since the beginning of the disease development. So you can also test the primary tumor, not only the metastasis. You can test the tissue and not the blood. Or you can also test the blood, but I mean, you can find it in the tissue as well. So far, normally we test at progression on CDK4/6 inhibitor. However, very soon we are going to have the INAVO 120 combination, which is inavolisib, the PI3K inhibitor by Roche in the first line endocrine resistance setting. So in that case, we are going to test for PI3K at the diagnosis of metastatic disease. And then we are going to test for ESR1 alteration at the time of progression to AI plus CDK4/6 inhibitor, preferring the tissue for PI3K and the blood for ESR1, but you can test both of them in the other biological material. And then for the other question, the choice of the second line therapy in ER-positive, HER2-negative disease is strongly dependent by the biomarker. So as I mentioned, PI3K, AKT, PTEN, ESR1 or no alteration. And then the second important point is the PFS to first line treatment. So a patient with a very short PFS to first line therapy, not sure I will go for a second line endocrine-based therapy. For example, a patient that progressed within 6 months after initiating first line treatment. The longer the PFS to first line, for sure, the more I will give a second line endocrine-based therapy, biomarker driven. So like using the biomarker and the drugs that I've mentioned. With the studies presented at ESMO and also with the EMBER-3 data with imlunestrant abemaciclib, I think that this concept of biomarker testing may become probably even more complicated because it seems that all comer benefit from this combination treatment, which to me are the best therapies in the post CDK4/6 inhibitor space. Single agent endocrine therapy, particularly single agent fulvestrant, has a very, very short PFS, very short, very limited efficacy. And all the studies with combination therapies are those that have shown the longest PFS data. So I will be very keen to have giredestrant everolimus, for example, as a treatment option, potentially in all comer.
谢谢。那么这个问题，刚才我们讨论
Thank
这
you
个问
very
题，
much.
钱教授，
So, Professor Quan, for the questions that we have discussed, what do you think for triple negative, right? For triple negative breast cancer, because it's advanced stage, I think the previous speakers has already shared very comprehensive information for the first line therapy in terms of treatment selection for the first line. We don't have much options in the first line in China. So for triple negative and mostly chemo, right now for immunotherapies, we have a very limited option. So based on the actual practice in clinical circumstances so far, based on evidence that we have and considering the affordability and accessibility, I think we also need to have all three of them being considered. If you only have 2-3 months of PFS extension, however, you still have pay a lot of money, suffered from a lot of adverse events, I probably will not choose that. And then I would like to talk about for the endocrine therapy in the enhanced adjuvant setting. So previously, we have already talked about Monarch E trial. So for HR positive, HER2 negative patients, we know that now for early stage breast cancer, we're trying to achieve cure for these patients, reduce the risk of relapse. So far, now with the pass of time in our clinical practice, we have tamoxifen and also AI or, for example, the OFS and also the Monarch E and NATALEE trial. So basically, we have been escalating to reduce the risk of relapse. So my question is, for Monarch E and NATALEE trial, both has achieved a very good result in the adjuvant setting with the enhancing treatment, but the treatment duration is different. One is 2 years and the other is 3 years. For breast cancer, the peak of recurrence is usually 2-3 years. So for endocrine therapy, we continue endocrine therapy considering the risk of recurrence. So in the adjuvant setting for enhancing treatment, if both are available, then for 2 years and 3 years in NATALEE and abemaciclib, what's your consideration? How do you consider? How do you choose? Professor Lambertini?
Yeah, sorry, I think I missed part of the question if it's between the choice of abema versus ribo in the adjuvant setting. So as I've mentioned at the end of my presentation, I do believe that the strength of recommendation so far is stronger for abema versus ribo because of the longer follow-up, the OS data, and the fact that you use a shorter duration of a CDK4/6 inhibitor, which is very important. I mean, we will decrease the number of consultations significantly from 2 years or 3 years CDK4/6 inhibitor treatment. So in patients with the overlapping criteria, I would tend to prefer abemaciclib. Of course, I will discuss toxicity profile and so on with the patient, but based on the OS data and the shorter duration, I will prefer to use abema in this setting. For patients that are eligible only to ribociclib, I'm using it in my practice. However, I'm not fully convinced that all the patients that were eligible to NATALEE have a sort of high-risk features to escalate the endocrine therapy. So for some of these patients, the lowest risk patient population in the NATALEE trial, I'm not sure that we should escalate endocrine therapy. So I'm thinking about, for example, a 22 millimeter tumor, grade 2, non-negative, 21% Ki-67. To me, this is a patient that has not a high risk of recurrence to justify treatment escalation, even though she was eligible to be included in the NATALEE trial. So this is my approach.
好，谢谢。那么那
Thank you.
个最后我想问一下
Thank you very much. And for DB11 study, I also have a question. That's for neoadjuvant, but they use TDXD, follow THP, and DDAC, follow THP. So in this study, if we compare the PCR, if patients achieve PCR, should we use HP for 1 year or use TDXD? So Professor Ying, what's your opinion? Thank you. So for DB11 study, so I think that's also a question that has been frequently utilized for TPYH. is docetaxel with small and big moleculars. In the neoadjuvant, it has also been approved. I mean, for patients that are PCR, non-PCR, how can we make the choice? It's the same principle. Right now, we don't have any clinical evidences to support choice of the ADC or the HP. I think this is a very good clinical question for future studies. But if we want to verify that, I think we can only do clinical trials to verify the right choice. I mean, if you use TDXD, follow THP, and if we achieve PCR, following that, we didn't have answer or consensus for that. Of course, you can refer to past trials. I mean, for PCR patients, maybe I just can use HP because TDXD may have higher toxicity. But for non-PCR patients, in clinical practice, maybe they have the resistant issue, and maybe we need to switch to TDM1. So I think right now there is no right answer or confirmed answer to that. We still need to do more clinical trials to verify the choice. I mean, you can make the comparison. And so for PCR patients, you have TDXD, TDM1, and THP group to make the comparisons and then to see which one is superior in terms of the PFS, DFS, etc. So for this question, our understanding is that we know that for HER2-targeted therapy, for adjuvant treatment, we have the comparison of 2 year, 1 year, and a half year. Then we see 1 year is the best for the HER2 ADC drugs. We see many of the new drugs that are emerging. In the future, we're going to have new ADCs. So firstly, for the NPC patients, we will check the PFS. That's the first thing to do. It's easy to have positive result. I mean, in neoadjuvant, if we use it, I think, of course, we still have those questions because in neoadjuvant, if we do clinical trial, that's okay. I mean, with those data, we're able to verify our hypothesis. But after neoadjuvant, for PCR patients, for adjuvant treatment duration, there is no solid data to give us an answer. I mean, in many countries, another studies are going on. In China, we have puritinib. In neoadjuvant, it also shows some efficacy if we achieve PCR. How long should we treat for adjuvant setting? So I think we need to follow up at least 5 years to see DFS OS data. Then we're able to have the answer saying that maybe like a 1 year maintenance is good enough. For other ADC drugs for the HER2, I think we also need to have more data to give us the answer, especially for HER2 target ADC drugs. We're going to see more and more of it. And many of those patients will also go to receive neoadjuvant treatment because nowadays with the readouts of the neoadjuvant studies, we see this trend. So I think in order to answer this question, we need to have more adjuvant setting clinical trials to give us more data and evidence to tell us the right answer to make the right decision. Okay, thank you. I want to thank the two foreign speakers for the wonderful sharing. Your talks are very informative. Each of you share with us 6 to 7 clinical trials. I also want to thank the 4 panelists for the wonderful discussion. Okay, this is the end of today's meeting.